Good afternoon. My name is Inez Ponce, and I am the director here at the UCLA Center for Health Policy Research. Welcome to today's seminar. Today's seminar is Identifying Mental Health Needs in California, a Public Health Approach. We know from research that there are harmful effects of mental illness and stress on health. In California in 2018, an alarming 3.2 million adults reported that they experienced serious psychological distress, many who also experienced social life and work impairment. And we know this from the California Health Interview Survey. There have been numerous challenges and victories to pass laws that make it easier to treat people who grapple with mental health issues. For example, the 2004 passage of the Mental Health Services Act through Proposition 63 provided funding, workforce personnel, and other resources to support county mental health programs. So today's discussion will delve deeper into using a public health approach to look at those who are at risk of experiencing psychological distress. We hope that the data will be useful in informing programs and policies and interventions that may take a preventive approach in addressing mental health needs. If you're interested in today's slides, you can get copies. You can request them from the communications department and at the email address shown here. Please stay tuned for other announcements on the 2020 Health Policy Seminar Series. And we hope you enjoy today's talk, and we wish you all happy holidays. So now let's begin today's discussion with Dr. Imelda Padilla-Frausto, who is a research scientist here at the Center for Health Policy Research. Dr. Frausto Padilla.
Well, good afternoon, everyone, and thank you for coming, for those in person, and thank you for joining us for those that are online. Today's talk, I'm going to give a little bit of a background of why this is important. I'll go over a conceptual framework that I'm working on, go over my methods that I've used, and then I'll go over some preliminary results, and those will be broken down into three different sections. The first is identifying adults with mental health needs, and then we'll look at the consequences on work and life impairment for those with mental health needs. And then lastly, we'll look at those who are not receiving access to mental health care. Then we'll conclude with a discussion and questions and answers. I'll leave some time at the end for those. Before I begin, I want to thank the funders of the Mental Health Questions in CHIS, the Mental Health Services Division in the California Department of Healthcare Services. I want to thank the communications team for all their effort and work in helping bring this presentation together, our IT team for the technology that allows everyone to view this, and lastly but not least, Inez and Steve for their support. So why is mental health important? 1 in 4 people will have a mental health disorder in their lifetime. These mental health disorders create a significant burden on health and productivity of those impacted. 15% of disease burden is attributed to mental health disorders. This exceeds disease burden for all cancers. Mental health disorders are also the leading cause of disability in the US for those adults ages 15 to 44. It is also the costliest condition in the US at $200 billion in 2013. Researcher Charles Roehrig, founding director of the Michigan-based Center for Sustainable Health Spending, examined approximately 10 different categories of conditions using the most recent estimates available from the National Health Expenditure Accounts provided by the US Centers for Medicare and Medicaid Services. Heart conditions were the second costliest condition, falling far behind mental disorders at $147 billion. Trauma and injury was the third at $143 billion. This is quite significant. It is significant because only 1 in 2 people with a mental health disorder will receive care. This is an unfortunate statistics because there are effective treatments for mental health disorders. There are effective interdisciplinary strategies for prevention and early intervention that help to reduce risk factors and increase protective factors. So who receives mental health services? We often think of those with the most severe mental illnesses that receive services. And for the most part, this is accurate. And so if we look at this, use this triangle to give an example of what this is the general population, we see that a very small proportion of the general population actually has a severe mental illness, and they're also the ones who are most likely to receive services. While this population is an important population to focus on, oftentimes limited funding limits the amount of services that can be provided beyond this population. However, these types of services are often reactive and provide services only after a person's symptoms have become severe and debilitating. In California, I think we can do better than this. When we take a public health framework, we see that these folks are often what we call those who are seen at the tertiary level. The tertiary prevention level aims to reduce the consequences of established disease and disability. This is often the focus of our mental health services. However, there are other populations who could benefit from early intervention and prevention. We call this the secondary prevention level, which aims to prevent the progression of disease and disability. And lastly, we have primary prevention, which aims to limit the incidence of disease and disability in the population. Thankfully, in California, we do have the Mental Health Services Act, also known as the Millionaire's Tax. This provides increased funding for personnel and other resources to support county mental health programs and monitor progress towards statewide goals for children, transition age youth, adults, older adults, and families. The Act addresses a broad continuum of prevention, early intervention, and treatment service needs, lining up very nicely with the public health framework. But how do we know who is in need of these services? Oftentimes, research and data often focuses on those at the tertiary level. But we know that there are other folks who can benefit from these earlier interventions and prevention services. So applying the public health framework with what the Mental Health Services Act is intending to do, I say that at the tertiary level, we have treatment, which aims to reduce the consequences of established mental disorders. This would include interventions that reduce disability, enhance rehabilitation and recovery, and prevent relapses and recurrences of these disorders. Many of our services do this. Then at the secondary level, I propose early intervention, which aims to prevent the progression of mental disorders. And we can use this as a way to lower the rate of established cases of the disorder or illness in the population through early detection, screening, and treatment of these disorders for those who may or may not meet diagnostic criteria that is often used for tertiary prevention. And lastly, we have prevention, which aims to limit the incidence of mental health disorders in the population. And that population will be another topic. For now, I'm really focusing on the tertiary, those that could benefit from tertiary prevention and secondary prevention. So how do we know how we allocate resources? How many people are in need of these resources? One way I'm proposing to identify mental health need in the state of California is using the Kessler Six that is used in the California Health Interview Survey. It is a 6-item scale which asks 6 questions. How often do you feel nervous? How often do you feel hopeless? How often do you feel restless or fidgety? How often do you feel depressed that nothing could cheer you up? How often did you feel that everything was an effort? And how often did you feel worthless? This scale has been used in validation research that does get at those with serious mental illnesses. Some other research has also looked at lower levels on the score of the Kessler Six to get at more, we want to call that moderate psychological distress, which may be those who are not meeting diagnostic criteria for diagnosable disorder. Responses to these questions are all the time, most of the time, some of the time, a little, and none of the time. These questions are summed and scored and provides a range of 0 to 4 on these questions. In the past, we have used a score of 13 or greater to identify those with serious psychological distress. I am proposing that we also use a score of 9 through 12 to get at those with moderate psychological distress. Other research has also looked at the Kessler Six and validated this measure for moderate psychological distress. Some have suggested going as low as 5. For the purposes of this study, we are looking at 9 through 12. And then we could also use scores of 1 through 8 to get at low psychological distress. And we can think about this as low psychological distress as sort of like a low-grade fever. Like, it's not something that needs urgent attention, but it's something that's kind of making somebody not feel so well, right? And could use some sort of intervention. And moderate psychological distress we could think of as a fever, having a fever, needing some sort of intervention. And serious psychological distress as somebody with a high fever needing immediate attention. So that's just one way to think about these different levels. So applying that to my conceptual framework, I do think of tertiary care as those with serious psychological distress, so identifying those with moderate psychological distress for early intervention, and those with low and no psychological distress for prevention. And this is a conceptual framework that I'm using to look at CHIS data. So using the 2018 data from the California Health Interview Survey, I looked at these outcomes. CHIS is also a household survey, so I want to be mindful that these estimates that I'll be providing actually underestimate the need for mental health care, because it does not look at those who are incarcerated, those who are institutionalized, or those who are homeless. CHIS has a robust sample and provides survey weights to give us population estimates. And CHIS is also done in 7 languages to get at the diversity in California. So what we find in 2008 is that 10.9% of California adults age 18 and over have serious psychological distress. That's approximately 3.2 million adults in California. Looking at moderate psychological distress, we see that 9.9% of adults have moderate psychological distress. That's an additional 2.9 million adults in California. Then looking at low psychological distress, again, sort of this low-grade fever, we find almost 2/3 of California adults who identified with some sort of symptomology, and that's an additional 18 million. And then 18.2% of adults scored 0 on the psychological distress scale. When we look at this by gender, what we see is that women are more often to have psychological distress, with 12.1% of women in California with serious psychological distress compared to 9.7% 1.4 million of men. We also see that men and women tend to have similar rates of moderate psychological distress, with 10.2% and 9.6%. They seem to have similar rates in low psychological distress, with almost 2/3 in each group. When we look at levels of psychological distress by age, we see that the young adults are the ones that are disproportionately impacted by serious and moderate psychological distress. And we see sort of this age gradient with lower levels decreasing as we age. So what is it about those who are 18 to 25 that creates these higher levels of need? That is an important population to focus services on. When we look at levels of psychological distress by race and ethnicity, what we see is this particular group that identify as other or two or more races that have the highest rates of psychological distress in both serious and moderate. These are significantly different from non-Latino whites that have 10% and African Americans that have 9%. But as you can see, overall, all groups are impacted by different levels of psychological distress. When we look at poverty level, we also see an income gradient for those suffering from psychological distress. Those in poverty with low incomes are disproportionately impacted by different levels of psychological distress, but it also goes up to 300% of the federal poverty level that are disproportionately impacted by psychological distress. When we look at this by family type, what we see is those who are married have lower levels of psychological distress. So marriage is often a protective factor among those who are married. What we see here is that those married with children have slightly higher levels of distress, which may go without saying. However, among those who are single, it's interesting because we see the reverse. And those having children, it seems to be a protective factor for those who are single. There are some hypotheses about why that may be, but I'll leave that up to further exploration. When we look at education, we often think of those with lower education having higher levels of psychological distress. But what we're seeing is this really interesting trend with those having some college. And so these are folks who either have an associate's degree or who started in a 4-year college degree but never completed. These folks actually have the highest levels of psychological distress in both moderate and serious. Initially, we thought maybe this was due to the higher levels of those who are age 18 to 25. So I did another set of analyses, took those higher groups out, those 18 to 25-year-olds that would, possibly skew that. And it didn't pan out the way we thought it might happen. So there needs to be further research for these folks with some college. What is it about these particular folks that they're having higher psychological distress? Is it that they wanted, to achieve higher, but weren't able to, and therefore are stuck in, jobs or positions, or having financial distress because they weren't able to achieve their goals. So this is an interesting population that needs more attention. Then when we look at health insurance type, what we see is those who are on public insurance or who are uninsured have higher levels of psychological distress in both serious and moderate. I wanted to get a better sense of who was in the uninsured population, and what I found was 60% of those uninsured are Latino, 20% are non-Latino white, and 12% are Asian. I also wanted to look at this by income, and what I found was 38%, so over a third of those in the uninsured population actually have incomes over 300% of the FPL. So this is a very interesting group as well, because we often think of the uninsured as those who are low income, often Latino. And what we're seeing is this is actually a little bit of a higher income population. So what is it about these folks that that would increase their psychological distress? Public insurance, we often think about those who are in poverty, so possibly, financial stressors. So that would also, so that would lead to higher levels of psychological distress. So that one tends to make sense. It's this uninsured population that I think needs more investigation. So I just want to provide a summary of those socio demographics. Young adults age 18 to 34, especially those under age 26, have higher rates of psychological distress. The multiracial population also had higher rates. This is a group that consists mostly of American Indian, Alaskan Native, and African Americans. Adults living in poverty suffer the most, but also those who are up to 300% of the FPL have high rates of psychological distress. The other important group is single adults, especially those without children. And then we have adults with less than a high school education, but as we saw with the data, those with some college actually had higher rates. And so that's a very important population to look at. And then lastly, adults with public insurance and those who are uninsured. So next I wanted to look at what are the consequences of moderate and severe psychological distress. So I looked at some work and life impairment. I used the Sheehan Disability Scale that is in CHIS. It is asked only of those scoring a moderate or serious psychological level of distress. So that's a Kessler Six score greater than 8. These questions ask respondents to think about the month in the past 12 months when they were at their worst emotionally. Then they are asked, did your emotions interfere with your performance at work? These questions are only asked to those who are working. Then they ask, did your emotions interfere with your household chores? Did your emotions interfere with your social life? And did your emotions interfere with your relationships with family or friends? Responses are a lot, some, or not at all. And so I looked at these individually by different levels of psychological distress. So on the left-hand side, we have the 2.6 million adults with serious psychological distress who are working. So this is looking at work impairment. Up to 8 in 10 adults with psychological distress are impaired at work among those with serious psychological distress. So the orange guys at the top are moderate impairment, and the red guys at the bottom are severe impairment. And on the left-hand side, we have those with serious psychological distress, and on the right-hand side, we have those with moderate psychological distress. And so consistent with other research, those with serious psychological distress have higher rates of impairment. And those with moderate psychological distress have somewhat similar rates of impairment, but those tend to be more moderate levels of impairment. When we look at impairment with household chores, we found that up to 8 in 10 adults with psychological distress are impaired at home. Those with serious psychological distress are more likely to have severe impairment than moderate impairment, and those with moderate psychological distress are more likely to have moderate impairment than severe impairment. Looking at those who said they were impaired in their social life, up to 9 in 10 adults with psychological distress are impaired in their social life. So among those with severe psychological distress, they're more likely to have severe impairment in their social life. Among those with moderate psychological distress, they're almost equivalent in their levels of serious and moderate psychological distress, but tend a little bit more towards moderate psychological distress. And then when we look at impairment with relationships with friends and families, we found again up to 9 in 10 adults with psychological distress are having relationship issues. So among those with serious psychological distress, you see that they have higher levels of severe impairment, but also pretty high levels of moderate impairment. And those with moderate psychological distress are more likely to have moderate impairment, but some actually have some severe impairment as well. Definitely a high need population of those with moderate impairment as well. So just to provide like a summary slide of looking at these life and work domains in comparison, what we see on the left-hand side is those with serious psychological distress are more likely to have severe impairment across all work and life domains. And for those with moderate impairment, moderate psychological distress on the right-hand side, they are more likely to respond with moderate impairment, although there are some responding with severe impairment across all life domains. Next, I wanted to look at who's receiving care. When we look at the combination of severe psychological distress and impairment, who's receiving the most care and who's not receiving care? So we looked at access to mental health care. There are 2 questions in CHIS. One asks, in the past 12 months, have you seen your primary care physician for problems with your mental health, emotions, nerves, or your use of alcohol or drugs? The second question asks, in the past 12 months, have you seen any other professional, such as a counselor, psychiatrist, or social worker for problems with your emotions, mental health, and nerves, and use of alcohol and drugs? So we asked both of the medical field and of the mental health professionals. A no response to both of these questions is my outcome that I'm interested in, so they did not see any type of professional provider for mental health. So when I look at those with serious psychological distress and severe impairment, what we're seeing is about 1/3 who are not receiving the care they need. When we look at those with serious psychological distress and moderate impairment, we're seeing about half who are not receiving the care they need. Predominantly, research shows that almost 40 to 50% of those with mental health needs are not receiving the care they need. So combining these 2 groups, we see that 40 to 50%. Among those with moderate psychological distress and who reported severe impairment, we're seeing about 2/3 who are not receiving care. These are the folks that could really benefit from early intervention. And then among those with moderate psychological distress and moderate impairment across all life, work, and life domains, we're seeing about 7 in 10 adults with moderate psychological distress and moderate impairment who are not receiving services. So to summarize, California adults have a lot of need for mental health care. We have 3.2 million adults with serious psychological distress. We have 2.9 million with moderate psychological distress. The consequences of mental health needs are not insignificant. When we see up to 8 in 10 adults with psychological distress who are impaired at work, that's a cost to, an economic cost, if you will. We also see that they are also impaired at home. Up to 9 in 10 adults with psychological distress are impaired in their social life, and they're also impaired in their relationships with family and friends. And even though household chores, social life, and relationship with family and friends doesn't have a direct impact on work, there is an indirect impact nonetheless. For those who are not receiving access to care, among those with serious psychological distress, 1 in 3 with severe impairment are not receiving the care that they need. 1 in 2 with moderate impairment are not receiving the care that they need. Among those with moderate psychological distress, we're seeing almost 2 in 3 with severe impairment who are not receiving the care that they need. And about 7 in 10 of those with moderate impairment who are not receiving the care that they need. I believe this data from CHIS could be used statewide as a mental health surveillance tool to track how we're doing in reducing these numbers across all distresses, levels of distress, and all levels of impairment. We do have MHSA funding that is intended and earmarked to increase services beyond those with serious mental illnesses. We have funding for early intervention and prevention services. And so I think we could use this data to help allocate resources and funding for those other levels of prevention. It could also be used to address workforce shortages. We know in California that there's a vast workforce shortage in mental health care. We really need to get on top of that. For MHSA county plans and updates, I could see this data being used in their program planning, for their resource allocation, for informing innovative programs and services for those with moderate psychological distress. And these are folks who may not meet that criteria for having a diagnosable disorder. But as we saw with the levels of impairment, there is a need for early intervention and prevention services. And so with that, I thank you all, and I am open for questions.
Thank you, Imelda. Great presentation. I was hoping you could help us understand a little bit more about the significance of the K6 score, because for one thing, I thought that it was actually a measure of at risk rather than actual psychological distress, but that could be just me. But tell us a little bit about how the measure corresponds to specific actual mental health conditions, and what is it really picking up? Particularly if you look at the questions that are used in the survey, they seem to be, I'm not a mental health professional, but you know, there's depression and anxiety often are what is picked up by these kind of measures. So what are we, it helps us understand what are we really looking at?
Right. So the Kessler Six has been used worldwide, nationally, as a way to get at those with serious mental illnesses. And it has been validated in clinical studies to capture those with diagnosable disorders. And you're right, these are questions that get at more like depression and anxiety. And that often is correlated with those with serious mental illness. And so what this does not actually get at is those with maybe psychosis, with more severe mental illnesses, such as schizophrenia or bipolar, but depression and anxiety often coexist with these disorders as well. So the Kessler Six has been rigorously tested and validated for looking at and estimating people with serious mental illnesses. And by that, I mean more so along the depression and anxiety scale.
Because some of these are temporary too, because this is looking at the last month, right?
This is actually looking in the past year.
The questions are asking about last month.
It asks about both, actually. So it actually about, so it actually about the last 30 days. And then they ask if there's a month in the past 12 months where their levels were, where their symptoms were worse. And then they ask about that month. So it is in the past year. Yeah.
Thanks. You know, the data on the relationship with the income, education, and you know, others are interesting. But since just is a cross-sectional data, you don't know which one comes first. And
Correct.
so based on the other study, you know, what direction it pointed to? Like, you know, the mental health issue come first or the low education come first?
Right. No, that's a very good question. And I think longitudinal studies have actually found that it is stressors, life stressors that happen first, and then the mental health disorders happen next. And so it often is that direction. Yeah. And since this is as you said, this is a cross-sectional data, and so we can't really get at that direction, but it can actually go both ways. And so other data actually shows a downward social spiral for those with like more severe mental illness. So like schizophrenia or bipolar, their illnesses become so severe that they actually have a downward social mobility. And so that actually leads to lower income, possible lower education. Many of these disorders do happen in young adulthood. And so when you're thinking about those who are starting college, that's oftentimes when disorders start presenting themselves. It can happen in adolescence as well. So it's important to really screen early and prevent, right? And so if you provide them with the resources and tools that they need before they go off to college, or even while they're in high school, maybe we'll see a less prevalence of mental disorders in the population.
Thanks so much, Imelda. It's Ninez. Can you just put the slide on when you showed the moderate and the estimates, because it was about almost 3 million with the moderate. So I thought that this data was really important to highlight that group.
Yes.
But I am actually on to tell you about some questions on the chat. Michael Samuels said, great presentation and data. And do you think there might be some confounding between education and migrant status, country of birth, and that all things being equal, migrants tend to have less education, be physically healthier, and perhaps healthier with respect to mental health?
Yes, I do believe there's a lot of confounding there. And I will be looking at this and more regression analysis where we can actually parse out those different factors and look at them together. So that's very good point.
Great point, thank you. And Harry Pudell says, nice presentation. I'm also using K6 scale to examine psychological distress among Asian Americans. I'm wondering, how do you capture cultural effects in your study, since stigma is highly associated with mental well-being among Asian culture?
Yes, that's a very good question. And I think the one way we get at that, I think, through CHIS is by asking these questions in Asian languages. I do agree that there are cultural factors and stigma that may be associated with answering these questions. And so it may be possible that these are underestimates uh, of psychological distress for these particular populations. And I do believe there needs to be more possibly culturally sensitive questions and how we get at those, ask those questions for particular populations.
Thank you. Hi, my name is Masood Agahi. I'm actually a physician and just had a comment and then a question related to my comment. As a physician, I never heard of Kessler Six, and I could immediately see how so easy that I could put these questions on a flashcard and have it in my waiting room for
Yes.
patients while they're waiting to answer, and for me immediately refer them to somebody. So in terms of actionable items like that, something simple like that,
Mhm.
are there any specific recommendations? Because I think there's a severe lack of knowledge on the side of the primary care physicians. I'm not a primary care physician, but after 20 years in practice as a surgeon, I realized there's a huge gap of knowledge about public health in general that are important in practice of medicine. And I'm back in school now, and I'm in the executive MPH program to pick that up on my own. What are any actionable items that you're aware of that can actually be instituted?
Yeah, I think that's a really great practice is being able to screen for these levels of psychological distress. There are a lot of efforts that are being made to integrating mental health or behavioral health into primary care settings. And so I think screening is would be a big help at any level in the medical field. I also think screening in schools should be also done. I think if we screened more in schools, we could help a larger population of adolescents who may be experiencing lower levels of psychological distress and being able to help them early on. I hope I answered your question, and I'm happy that you're back in school and getting your MPH.
So a little different question. So
Sure.
there were a number of slides on impact in different aspects of life, work and family and social life. So can you give maybe some examples of, so in this one, the severe impairment in work, when people say that they're severely impaired at work by their emotions, what types of things would that be? And then how might you translate that? So the very first slide, you talked about the dollar impact. I think a lot of the dollar impact comes from these types of analyses. If you're severely impaired at work, you're only 50% as productive, and that generates billions of dollars of losses. So can you sort of walk us back, like if somebody says, yes, they're severely impaired at work, what that might look like, and then how that might translate into a dollar amount?
Okay, I'll try. Thank you, Steve. So again, since this is cross-sectional data, we can't say like work is causing the distress or distress is, but what we do know is that people with serious psychological distress are saying they're impaired at work. And what that does look like is presenteeism, right? Where people are showing up to work, but they're not fully there at work. And so I think in those situations, I think there's efforts at work that could be done, and the workforce, and providing benefits to employees mental health benefits so that they actually get the care that they need. And this also may be a time to, train supervisors and managers of what to look for when one of their employees isn't as productive as they were last year or something. And, that might be a red flag for an employer to screen or to sensitively talk to their employee about possible mental health concerns and getting them connected with appropriate professionals for that.
Sorry. Thank you, Melda. Great presentation. And
Thank you.
this is Riti Shankata, by the way. Just had a comment because the two questions we had online are very much related to some work Inez and I are doing. And I thought I would just shout out to that because we recently presented an abstract at the APHA meeting last month where we looked at Asians and Asian Americans and actually looked at the comment was about migrant status, but we were looking at psychological distress and suicide ideation comparing US-born Asian Americans to non-US born, and we see that US-born Asians excuse me, are more likely to report psychological distress as well as thoughts of suicide.
Yes, we also see that with the Latino population as well. And, it's very interesting that as migrants acculturate to US culture, maybe there's something about US culture we shouldn't be acculturating to, because we do see that, especially with later generations and US born, they are more likely to have rates of psychological distress similar to other US born populations. And there's a need there to reduce those levels of psychological distress. What is it in the earlier migrants? What are the protective factors? What are we losing along the way as we acculturate? Some hypothesize maybe it's community. Maybe it's family, maybe those are things we're losing as we acculturate. And it's, I'm not happy to hear that you find the same things with Asians, but it is something important to look at.
Hi, Imelda. This is Nani Part again. Could you talk about, we're looking at the chart where you show the prevalence of moderate and severe, and then the chart that you show the breakdown by insurance, and there's the rates of among the uninsured are also quite high, and especially among public insurance. There are implications here for the workforce. So, if you're now, this is a double-edged sword, I guess. With screening comes the need and the importance of being able to deal with it. And I can tell you that when you talk to sometimes some professionals, they say, screening is all well and good. We find out who needs it, and then we do not have capacity to provide the care. Could you talk about that?
Yeah, I would agree with that. And I do understand that double-edged sword, that the more we start identifying, the more workforce we need. And one way that I think some entities are dealing with that is more innovative ways of providing mental health care. For instance, telepsychiatry or telepsychology is one way of providing those services in meeting that gap in need. Another way is looking at these online applications sometimes of, there are these modules that people can go in and learn about what is depression, what is anxiety, what are the symptoms, how does this impact me? And so it's more like, self-care and more self-directed. And so these might be innovative ways of providing those types of services and meeting that gap, because I do agree with you. We screen, and then what? Where do we send them? We already have a shortage in mental health workforce as it is. So how can we think beyond what we already have. There are, peer support groups that may be one way of meeting that gap. And these online applications and telehealth is also another way.
Okay, from our remote participants, there's a question, and you started to answer this, Imelda, but what are some of the best ways to prevent stressors from turning into mental illness in that critical period of late adolescence, young adulthood? And what resources, studies can you share in that regard?
I don't have anything off the top of my head, but I do know that if we could provide more mental health services in middle school and high school, and providing adolescents with more tools, coping skills and coping tools, and how to deal with these life stressors, I think that would help a lot as they go into college and are, off on their own for their first time and experiencing more stressors. And I think if we intervene early, like I said earlier, by screening more in schools and finding out what the need is, and then being able to allocate resources and funding and programs to these schools, I think that would be a way to decrease the prevalence of disorders.
Yeah, I think that there's some hypothesis of social media could be one of the stressors, and I think we were able to examine that in CHIS with some questions on social media and associate it with some of these risk factors. This is a question that's not completely related, but we know Imelda's been working on this as well as Steve Wallace. Elder data from 2009, when will those data be updated by UCLA CHPR? You can sneak in some other questions that got completely related.
Get me while you have me on camera. I know, right? So we do have 2015 data up on our website. We have 2 dashboards that actually look at the cost of living for older adults, and we also look at the number of adults who fall below those thresholds. We have preliminary 2017 data for single, elders, and older couples. So if you want that data, you can email me. We haven't put it up on our website yet. We are anticipating to have 2019-20 data by early next year.
Thank you. And this is a question that maybe some clinicians who are joining us in our community right now can answer it. But one of the questions was, in Australia, all general practitioners screen using the Kessler 10. Is there a reason why there's a preference for PHQ 2 and 9 and GAD 7 over the Kessler tool here in the United States?
That's a really great question. I actually have no idea, but I do know in other projects that I'm working on, the PHQ 9 and the GAD 7 are often used. I don't know of any studies that have actually compared the validity of those 3 measures and what they're actually capturing. So that's a good question.
Yeah, I was just hoping there would be some responses here in our community on that. Any other questions in the room? Okay, well, I thank you.
Thank you.
Dr. Padilla-Frausto, for this excellent presentation. And again, happy holidays to everyone. And
yes, happy
we
holidays.
hope you can rejoin us in our webinar series in 2020. Thank you.